We will begin the questioning process, and I will begin with 5 minutes of questioning. Dr. Sardella, can you repeat for us, I think this was in your testimony, what percentage of the generic drugs are manufactured in facilities that have received an FDA warning letter? Yeah, turn your mic on.
1 out of 4 prescriptions in the United States over the last 26 months.
So roughly 25%.
Correct.
And over how many months?
The last 26 months.
And some of those FDA warning letters stay open for years, do they not?
That is correct. And the industry is less able, due to low margins, to be able to address them. And so their options are shutter, not comply, or continue to operate.
And let's talk about not compliance, because while some of these warning letters may be on things that folks back home might think are trivial and so forth, but there was an open warning letter on the New England Compounding Company at the time that they produced a sterile injection, which cost, I believe it was 38, 40 lives, several of whom were in my area. My district was impacted by that outbreak. And that was a warning letter because people were trying to cut costs. And so I want folks back home, and I think you would agree with me, that when you have 25% of your generic medicines being manufactured under a warning letter, most of it's not going to be a big deal. But some of it might be a big deal, and this is a concern that we need to take as a nation. Would you agree?
I agree, Chairman. In that spectrum, there are very much warning letters that don't imply any type of safety issue, but there's also those that do, and those are significant and have dire consequences.
Yeah, and that's my concern here, is that, you know, in our race to save a few pennies here and there, we're sacrificing both availability that Ms. Bray talked about and quality. All right, back to my real questions, the ones that I had prepared in advance. In your white paper, Dr. Sardella, you wrote that it's unrealistic to fully move our API sourcing and manufacturing onshore. Instead, you propose the U.S. API industry should achieve a minimum level of self-sustainability. Explain that for me.
We've done some research that estimates the cost to bringing the top 40 prescribed medicines and the top 40 essential medicines. We feel this would begin to stabilize the U.S. supply chain, reshoring those productions to the United States. Our estimates that would cost less than $2 billion, which is less than 1% of our total spend on pharmaceuticals for those generics, and allow us to have greater certainty and control of our drugs, knowing that the APIs are the clinical part of the drug that allows it to be create therapeutic. So,
and would you agree with me that it's likely, if we were to do something like that, then that would also encourage other folks to maybe make some more APIs that weren't in the top 40?
That's exactly correct. If we can think of them, we use at the API Innovation Center the construct of critical and essential. If one, critical being ones that are critical to our national security, those cardiovasculars that we take and patients take every single day, they're not in shortage, but they're core to our national security. The ability to incentivize production of those drugs here in the United States will allow for capability to produce the essentials in the United States, and therefore solving 2 of the issues, national security and our drug shortage for our essential medicines.
All right, you also talked about supply chain challenges and how that is exacerbated by inflexible regulations. Could you expand on that? And are there lessons we can learn from our experience in moving up the speed on COVID-19 that we should look to extend?
Yeah. Well, I think on COVID-19, there's some efforts to allow for greater inspections of different facilities to allow for better quality to be produced. I think a couple of the key things that we've learned is any type of expedited approvals or processing allow for faster time to market, allowing companies to have a quicker return on their investment on their capital.
I've got one more question for you, and I had some for the others, so I apologize, but I'm running out of time. Group purchasing organizations are considered the price setters for generic medications in our pharmacy supply chain, and they seem to create market inefficiencies. What role have they played in creating the current environment where we have shortages, and what accountability is there for GPOs when shortages occur?
The GPOs are contributing significantly to the aggregation of profits to them versus the manufacturers. They're putting the manufacturers out of business first. The second, I would caution, as we develop policy to address GPOs, recognize that any redistribution of those profits would go to foreign manufacturers, not U.S., because that's where they're getting their supply. If the goal is to create a sustainable, strong economic U.S.-based supply, those incentives have to be established before addressing the GPO's concentration of profits.
All right, I appreciate it. My time is up.